I was a discussant at, I think, Spotlight Session 14 on Immune-Oncology. In this, I summarized 3 abstracts. The first was related to the KEYNOTE-086 trial, which was a clinical trial in metastatic triple-negative breast cancer patients who received Pembrolizumab as monotherapy. So in these patients, the clinical outcomes were already published previously, but this abstract by Shireen Loy and colleagues focused on biomarkers of response in the patients on the trial. The findings focused on a couple categories. One was related to immune biomarkers of response, and these were all in baseline samples. And the authors showed that the baseline presence of a lymphoid infiltrate as measured by tumor-infiltrating lymphocytes, as well as a T-cell inflamed gene expression score, and also PD-L1 positivity was favorably correlated with response to Pembrolizumab monotherapy in these patients. And this was seen in the 2 different cohorts in the clinical trial, both in untreated PD-L1 positive metastatic triple-negative breast cancer patients and also in those that were on the second line or later therapy. The other category of biomarkers was related to mutational burden. So total mutational burden was also predictive of response in this clinical trial and was independently predictive. So while the immune markers correlated with each other, if you were positive for one, you tended to be more positive for another one of these immune biomarkers. That was not the case with the total mutational burden, which seemed to be an independent predictor from the lymphoid variables. They looked at some additional sort of suppressive immune features on their gene expression. Those didn't show any statistical significance. Then on my discussion of that abstract, a couple of the suggestions just in general for the field, where this is what we commonly see in having some biomarkers that do correlate to outcomes, but don't quite get us there of making the cutoff of who should or should not be treated, is to consider on-treatment biopsies, so on-treatment biomarkers after the patient's already started on treatment, and then looking. We previously published in melanoma, and now I'm looking in the breast cancer field, that on-treatment biopsy is more predictive of response when it comes to these immunotherapies than our baseline biopsies, which of course are easier to get in the clinical trial setting, but it may be worth trying to get the on-treatment as often as we can. The second abstract I summarized was the NCI I believe 1003 trial, and this one focused on a neoadjuvant or pre-surgical clinical trial in localized triple-negative breast cancer patients with Carboplatin and Paclitaxel chemotherapy for 12 weeks, followed by surgery, and then afterwards they could receive the rest of their standard treatment, which would include anthracycline. So their goal in this trial, and it was randomized, so they had a control arm of the regimen I just described, and then they had the experimental arm, which contained Atezolizumab in addition to this. And ultimately, from a clinical standpoint, they found an improvement in pathologic complete response rate. However, it was relatively low in the control arm at 18.8%. And in the experimental arm, it was significantly higher at 55.6%. But again, tougher to make that comparison given the standard of care arm was lower than expected in this setting. This clinical trial had ultimately 16 patients in the standard of care arm and 45 patients in the experimental arm. As a result, again, because of less patients in the control arm, that could explain potentially why that pathologic complete response rate was a little bit lower and potentially skewing the results. The other primary endpoint of this trial was to look and see if the tumor-infiltrating lymphocyte infiltrate was different with treatment and between arms. We didn't see any significant increase either within one of the 2 arms or between the arms. On my discussion of this abstract, try to put it in perspective with the other neoadjuvant clinical trials with PD-1 or PD-L1 immune checkpoint blockade that have been presented. Interestingly, we've seen in KEYNOTE-522 and in PASSION-31 that there is a significant increase in pathologic complete response rate when these immune checkpoint blockade agents are added on to an anthracycline-containing chemotherapy. But in the prior report of NEO-TRIP, which had a similar platinum and taxane regimen to this trial, when we added on this immunotherapy, we did not see that significant increase, and that potentially, is hypothesized to be related to the lack of anthracycline. But this current clinical trial adds additional sort of data to the literature. Here they were seeing some signal of effect. Whether that truly does indicate that there may be benefit in an anthracycline sparing regimen of adding this immune checkpoint blockade, or whether it was that this was a smaller trial and the results were skewed based on the low response rate seen on the pathologic complete response arm, we'll need to await additional ongoing trials to see. And then we'll need to await longer term follow-up from all of these trials to see what we observe on event-free survival rates. And the final abstract I summarized is about the Aipac trial, which looked at the addition of a LAG3 protein that is meant to stimulate MHC2 and thus promote antigen presentation. The addition of this to Paclitaxel containing chemotherapy regimen in metastatic hormone receptor-positive breast cancer. So patients were randomized to either the chemotherapy by itself or the addition of this LAG3 agonist for 6 months, 6 cycles of therapy, and then the chemo was stopped, and then you either continued on placebo or this immunotherapy. The trial did not meet its primary endpoint in showing there was a significant improvement in survival outcomes. However, it was interesting on their subgroup analysis because in those younger than 65, for example, they saw over a 7-month improvement in overall survival in that cohort. Potentially, this could be due to reversible defects in innate immunity that's being stimulated, and perhaps that's less reversible in the older population. So I think for this trial, it's actually really exciting to see that stimulants of innate immunity do have these effects. And I think the investigators are looking into doing a follow-up study focusing on that younger population, younger than 65. We'll also need to see how this compares to all the other agents that are targeting innate immunity, how their safety profile compares, how their efficacy compares. So it'll be exciting. But I think all in all, there were a lot of great immunotherapy studies in breast cancer and immune monitoring studies during the course of San Antonio Breast Cancer Symposium.